up with this like overwhelming, totally uncontrollable urge to just eat a bowl of dirt. Or I don't know, maybe you find yourself mindlessly chewing through 10 cups of crushed ice before lunch.
Yeah, I mean, you'd probably think you were completely losing your mind.
Yeah.
But it's actually your body screaming for a single elemental metal, which is iron.
Right. It's such a strange reaction.
It really is. It's a profound physiological SOS. We always tend to think of nutritional deficiencies as just, feeling a little bit run down.
Needing a nap or something.
Exactly. But when the body is starved of a fundamental building block like iron, the neurological and physiological responses become incredibly bizarre.
Well, welcome to the deep dive. Today, we are opening up this massive stack of clinical guidelines, retrospective cohort studies, and the absolute latest medical updates.
Yeah, some of these are as recent as April 2026, which is super exciting.
It is, and it's all focused on the treatment of iron deficiency and iron deficiency anemia in adults. The mission here is to really demystify these treatments for you, to bust some incredibly stubborn medical myths, and, to reveal why managing this seemingly simple nutrient is actually a really complex, high-stakes medical balancing act.
Right, and to really understand those stakes, we have to look at the sheer scale of the problem outlined in these sources. Because, honestly, the numbers are just staggering.
Oh, totally.
Like more than 1/4 of the global population is anemic. And about half of that massive global burden stems directly from iron deficiency.
Wait, a quarter of the entire world? That's wild.
I know, right? It's definitely not some niche medical issue. We are looking at a fundamental public health crisis that affects billions of people.
But treating that deficiency, like just throwing iron at the problem, that's really only half the battle, isn't it? I mean, if you've got a bucket that's losing water, you don't just keep refilling it. You have to find the hole.
Exactly. Finding the underlying cause is absolutely paramount before you even formulate a treatment plan.
Especially for certain demographics, right?
Yeah, especially in males and non-menstruating females. In those groups, a sudden drop in iron isn't usually just a dietary quirk. It often signals occult, meaning hidden gastrointestinal malignancies or bleeding lesions.
So essentially, it could be a sign of cancer or an ulcer?
Exactly. You absolutely must investigate where the iron is actually going before you attempt to replace it.
Okay, so let's assume the serious structural leaks have been ruled out, and we're just looking at the deficiency itself. Before we get into how modern medicine fixes the problem, we really need to understand how this actually manifests in the body.
Because it goes far beyond simply feeling sleepy.
Right, exactly. Let's go back to that dirt and ice craving we mentioned earlier. What is actually going on there?
So you're referring to pica, which is the compulsion to eat non-food items like dirt or clay. And then there's pagoprophagia, which is that intense craving for ice.
It's so weird that your brain's response to needing metal is to crave ice.
It is, but they are classic clinical manifestations. And there are other strange ones too, like bituria.
Right, where your urine turns reddish after eating beets.
Yeah, exactly. It happens due to the way iron deficiency actually alters absorption in the gut.
And we also see restless leg syndrome, which, I mean, it sounds mild, but it is actually intensely uncomfortable for people who have it.
Oh, absolutely. It completely disrupts your sleep, which obviously just compounds the overall exhaustion you're already feeling from the low iron.
And here's the real kicker for anyone listening to this. You might be dealing with these exact things right now and just brushing them off because your basic blood test said you aren't technically anemic.
And that is a really critical distinction to make. You do not have to have a critically low red blood cell count to feel terrible.
Because the tissue iron deficiency alone does enough damage.
Right. Even without full-blown anemia, tissue iron deficiency causes severe fatigue and drastically decreased athletic performance.
So if you're listening to this while going for a run and you're wondering why your mile time is totally tanked over the last 6 months, don't just assume you're getting out of shape. You really need to look at your ferritin.
Exactly. Ferritin is the protein that reflects the body's stored iron. And the standard goal is typically to push ferritin levels to at least 50 nanograms per milliliter.
But the sources say it's not a uniform target across the board, right?
It changes based on symptoms. If a patient is suffering from restless leg syndrome, the target shifts higher to greater than 75 nanograms per milliliter.
Oh, wow. That's a big jump. And what about for alopecia?
Yeah, for alopecia, which is hair loss directly related to the deficiency, clinicians want to see that number above 70.
See, this is usually where the average person gets their lab results. They see a low number and they just think, okay, no problem. I'll just eat more spinach or I'll order a big steak for dinner.
Right, the dietary fix.
Yeah. But the math in these clinical guidelines completely destroys the idea that you can just eat your way out of a true deficit.
The math is incredibly unforgiving. Let's look at menstruating females, for example. They require about 18 milligrams of iron daily just to maintain their baseline stores.
And what does the average diet actually provide?
The average diet only provides about 13 to 14 milligrams.
So you're already in the hole every single day. Even if you go out of your way to eat so-called iron-rich foods like fortified cereals, organ meats, dark leafy greens, you are still only getting a few extra milligrams per serving.
Exactly. Trying to fix a severe clinical iron deficiency with diet alone is like trying to refill a drained swimming pool with a garden hose that only drips.
That is the perfect analogy. So what about an iron multivitamin?
I mean, a healthy diet or an iron supplement is fantastic for long-term prevention,
Yeah.
but it is mathematically insufficient for treatment.
Right, the body just can't extract it fast enough.
Precisely. Your body simply cannot extract enough iron from food quickly enough to replace a massive deficit. To actually replete severely depleted stores, you need clinical intervention.
And oral supplements have their own massive hurdles, too. They are notorious for causing really severe gastrointestinal side effects.
Terrible stomach pain, constipation, nausea.
Yeah. And even when patients can tolerate them, it takes months to actually move the needle on those ferritin numbers.
Which is incredibly frustrating for the patient. Because the gut is such a huge bottleneck, medicine has increasingly turned to a workaround, basically bypassing the gut entirely with intravenous or 5E iron.
Which honestly seems like a total game changer.
It is a profound shift in hematology and general practice. By bypassing the digestive system, a clinician can completely replete a patient's iron stores in just 1 or 2 clinic visits.
That's incredible. And the broader implications of that are enormous, right? I'm looking at this landmark 2013 meta-analysis from the sources.
Oh yes, that meta-analysis definitively proved that administering 5E iron significantly reduces the overall need for red blood cell transfusions.
Which is a massive win for patients. Blood transfusions carry some heavy risks, like volume overload, immune reactions, transmission of pathogens.
Exactly. Using IV iron allows patients to just sidestep those transfusion-associated risks entirely.
And we are also seeing a major evolution in how that IV iron is actually delivered. The guidelines show a definitive shift towards single-dose infusions for outpatients.
Right, because the objective is to avoid unnecessary hospital visits and the inherent discomfort and risks of inserting extra IV lines over and over.
So what specific formulations are they preferring now?
Formulations like low molecular weight iron dextrin, ferric and ferromoxetol are strongly preferred. You can achieve full repletion in one single session with those.
Okay, but what about the products that require multiple infusions, like ferric gluconate and iron sucrose?
Those are mostly being reserved for dialysis patients now.
Which makes logistical sense, I guess, considering those patients are already sitting in a clinical chair multiple times a week anyway.
Exactly. It perfectly matches the pharmacology to the patient's logistical reality, minimizing disruption to their life.
Hold on, though. I really have to push back here on behalf of anyone who has spent even 5 minutes researching iron infusions online.
Uh-oh. The internet forums.
Yes, exactly. If IV iron is so efficient and you can get it done in one sitting, why isn't every single deficient patient getting it immediately? If you go on medical forums, you see absolute horror stories about severe, life-threatening allergic reactions, anaphylactic shock, people feeling like they are literally going to die in the clinic chair.
It is a totally pervasive fear, and honestly, it dictates a lot of medical behavior even today, but it's largely based on outdated history.
Really? So the horror stories are exaggerated?
Not exaggerated, just outdated. That high rate of severe allergic reactions was tied to a very specific older formulation called high molecular weight iron dextrin, or HMWID.
Oh, so the horror stories are real. They're just about a drug nobody even uses anymore.
Exactly. HMWID had an unacceptably high rate of anaphylaxis, and because of that, it was completely removed from the market. It is no longer used anywhere.
So what is the actual risk with the modern formulations we rely on today?
With modern formulas, true anaphylaxis is exceedingly rare. We're looking at an estimated incidence of less than 1 in 200,000 cases.
Wow. I mean, that is comparable to the risk of a severe allergic reaction from almost any basic, widely used medication.
It really is. But the lingering fear of IV iron allergies is so deeply ingrained in the culture of medicine that it actually creates a really dangerous dynamic in the clinic.
How so?
It frequently leads to doctors accidentally making a completely harmless side effect much, much worse. This brings us to what the literature calls the Fishbane reaction.
Okay, let's unpack this because it is one of the most fascinating clinical missteps in our sources today. What does a Fishbane reaction actually look like when it
So
happens?
it's a minor non-allergic infusion reaction. It occurs in less than 1% of patients receiving 5e iron, and the symptoms appear suddenly during the infusion.
What does the patient actually feel?
The patient experiences facial flushing and myalgias, which is a tightness and muscle pain specifically in the chest and back.
Okay, I mean, if I'm a nurse or a doctor and my patient suddenly turns bright red and grabs their chest, my immediate thought is that they're going into anaphylactic shock.
Of course, that is the medical reflex.
Hmm.
But the Feltbane reaction is not an allergy. It is believed to be caused by complement activation triggered by labile-free iron.
Labile-free iron.
Yeah, essentially, a tiny amount of the iron floating freely in the blood temporarily irritates the immune system.
Wait, hold on, let me translate that for a second.
Right.
When you say it's not an allergy, the sources specifically state it isn't mast cell mediated.
Correct.
And for you listening, the mast cell pathway is the classic allergic response, right? It's the system that makes us break out in hives from a bee sting or peanut allergy.
Exactly.
So you're saying if we look at the blood of a patient having a Fishbane reaction, the markers for that specific allergic reaction, the serum tryptase levels are totally flat.
They do not elevate at all.
No.
The flat serum tryptase proves definitively that we are not dealing with true life-threatening anaphylaxis.
It totally reminds me of a security system false alarm. It's like a dust bunny drifting past a motion sensor. The immune system spots the labile-free iron, flags it as an intruder, and sets off the alarms, the flushing, the chest tightness.
That's a great way to look at it.
But instead of the doctor realizing it's just dust, acknowledging the false alarm, and just turning the siren off, they hit the panic button.
They absolutely hit the panic button, and in this scenario, hitting the panic button means aggressively administering antihistamines.
Like what?
Specifically, doctors will push diphenhydramine, commonly known as Benadryl or even epinephrine in some cases.
They flood the building with chemical foam to stop a dust bunny. So what does pushing IV diphenhydramine actually do to the patient in that moment?
It causes immediate hypotension, which is a dangerous rapid drop in blood pressure, alongside tachycardia, which is a rapid heart rate.
Oh, wow.
Furthermore, it causes severe somnolence, making the patient incredibly drowsy and unresponsive. By administering the antihistamine, the medical team actually converts a minor harmless flush into a severe, terrifying cardiovascular event.
The treatment literally creates the emergency.
Exactly.
So what is the actual evidence-based protocol then? If a patient starts flushing and feeling that chest tightness, what should happen?
The most effective treatment for a minor Fishbane reaction is simply to pause the infusion and observe the patient.
Just wait.
Just wait. In almost all cases, the symptoms will resolve entirely on their own within a few minutes. And once the patient is comfortable, you just slowly resume the infusion. No Benadryl. Absolutely no H1 antihistamines.
Okay, but what about giving them medications before the infusion even starts, just to be safe, like pre-medicating them?
Pre-medication with steroids and H2 blockers should be strictly reserved for high-risk patients,
And who qualifies as high risk?
meaning those with a history of asthma, multiple severe drug allergies, or inflammatory arthritis. For the vast majority of people, pre-medicating actually increases the risk of an adverse event.
We have this massive irony where doctors are terrifying themselves and their patients over a complete myth.
It's incredibly frustrating to see in practice.
But as we pivot to the latest clinical data from April 2026, the irony gets even deeper. Because while everyone is watching the skin for an allergy that won't happen, a very real, incredibly dangerous side effect is happening deep inside the skeleton.
Yes. This is arguably the most significant paradigm shift in recent hematology. The danger centers around one specific widely used IV iron formulation called ferric carboxymaltose, or FCM.
This is the TriNetX database review, right? They looked at over 20,000 participants, which is a massive sample size. What did it reveal about FCM?
It revealed that FCM causes severe hypophosphatemia. This is a condition where the levels of phosphate in the patient's blood drop dangerously low.
Let's unpack the biological mechanics of that, because how does an iron infusion strip the blood of phosphate? The sources say FCM disrupts the degradation of a hormone called FGF23. How does that chain reaction actually work?
Okay, so FGF23 is a hormone that regulates phosphate. You can think of it as a balancer at the kidneys.
A bouncer, I like that.
Yeah, so when there is too much phosphate in the blood, FGF23 tells the kidneys to open the doors and dump the excess phosphate into the urine. Normally, the body constantly builds up and breaks down this hormone to keep phosphate levels perfectly balanced.
So under normal circumstances, the bouncer works a short shift and goes home. What does the FCM formulation do to the bouncer?
FCM chemically prevents the body from degrading FGF-23. The hormone stays active far longer than it ever